we're going to spend a lot of time comparing this afternoon. I'm going to describe 10 areas of clinical practice in frontline addiction treatment that are being transformed as we move from an acute care model of addiction treatment to a recovery management model. I want to begin by describing what an acute care model is. Number one, it's an encapsulated set of services, meaning we screen, we assess, we admit, we treat through whatever our philosophy and methods are. We discharge and we sever the service relationship. We tell people goodbye, have a good life. And in fact, if I find David has been maintaining email contact with the people he treated in the facility, if I find out he's been calling those people, I may fire him because that's a boundary violation of professional ethics, right? So, I mean, it's going to get kind of squirrely this afternoon because I'm going to tell you, today David may be fired. In the world I want to create in 5 years, we could give him an award for how well he's done that. Number two, a professional expert drives the process. What kind of power discrepancy? This is the expert model of addiction treatment. And what I want from a client is I want the client to come in and shut up and listen and let me tell them what they need to do. I do the diagnosis. I write the prescription of what they need to do. And if they don't do that, they're resistant and non-compliant. Next, individual, family, community is given the impression at discharge that recovery is now self-sustainable without ongoing professional assistance. That is what we convey, right? If we don't have long-term monitoring support plans, that is the message we are giving them. And the good news, as we said earlier, is some people's lives are transformed in this model. We do. We'll get about a third remission rates. Longer term. Those people with the clearest, simplest problem complexity and severity, with adequate recovery capital, will go through this and their lives can be transformed by it. But, and what we're going to do is begin to look at some of those buts. And this is going to be, we're going to begin to compare. As we break for lunch, I want to give you, we're going to do a little Q&A here just before we break. But I want to do one thing. I really want to emphasize this issue of acuity. How many of you believe that any healthcare institution should stay involved with the people they treat until the disorder being treated can be self-managed by the patient and their family on their own resources? So whatever that time is, and it's going to differ dramatically depending on what the disorder is, agree? So let's use an example. Let's talk about cancer for a minute. When we intervene with cancer, and we do through a variety of ways, but almost across the spectrum of cancers, how long are we involved? Well, in some cases till they die, but there's an exception to that, and that's this. What we know in cancer is there's a high risk for reoccurrence of cancer within the first 5 years following primary treatment. So what do we do in that 5-year window of greatest vulnerability? I mean, and we do this, we're starting to do this very well in the United States. Some of you may have gone through, your families have gone through. What do? I mean, we're doing this incredible close monitoring and screening, and home nurses coming to visit us at home. When we won't show up, they come get us. We're going in, we're doing all the screenings, the blood work, and we keep doing that. And then when we get to the 5-year, what happens? Man, we celebrate. I got there. Because when we hit the 5-year window, what do we know? Because the odds of me relapsing later in my life have almost gone back to what it is in the normal population as far as the risk. But before I get to that 5-year, I know I'm walking on broken glass here. It's a scary time period. So here's the issue for recovery. When is recovery stable? Are you with me? When does my sobriety and health today predict sobriety for a lifetime? Do we have any data that helps inform that for us? And the answer is we do. Because when it comes to alcohol dependence, Severe complex alcohol problems, we know the stability point of recovery is 4 to 5 years. Let me tell you how we operationalize that in research. We say, when does the risk of this person ever relapsing again in their lifetime drop below 15%? Below 15%. So what it says is, if you maintain 5 years of uninterrupted sobriety, you have an 85% chance of never tasting alcohol the rest of your life till you die. But before that, what? 4 years gets to be a little more predictive, 3 years a little more, 2 years sort of, a year don't tell us much. Doesn't tell us much. And 6 months doesn't tell us anything. Because there are a whole lot of people that have short periods of sobriety that aren't recovery. That's part of their addiction cycle, right? I mean, so that's not predictive of anything. That's part of an addiction career, not a recovery career. So if we know that 5 years is a stability point for alcohol, and for other drugs, we know it may even be less stable. For example, 25% of heroin addicts who achieve first 5 years drug-free from heroin, 25% will eventually relapse back to active narcotic addiction. So that's about 10% higher than the alcohol data, right? Now what about methamphetamine? Got no idea. What about cannabis dependence? Don't have a clue. Why don't we have a clue? Because nobody studied the recovery cycles. We haven't followed people out far enough to know. The only data we got is for alcohol, and even, is prescription opiates different than the data we have for heroin addiction? Don't have a clue. Simply don't know. But if we use that data as a baseline, how long should we be involved? We said the principle was we stay involved until the individual and the family can self-manage that disorder on their own resources. We have no data on cocaine that goes out that far. Yeah, these are the first, these are almost all treatment samples. So these are individuals who've been treated. These are large samples. I mean, I don't think we've got a single sample that I'm referring to, the less than 1,000 people in treatment. But Chicago samples that we've done this work on, our data comes in a little bit lower. We get a stability point about 4 years. And after that, only about 13 to 14% will relapse. Absolutely, yeah. We got more statisticians than I can even count at this joint. These tend to be, for the opiate data, these tend to be large urban areas. These tend to be studies that have been done in San Francisco and Chicago and Detroit, particularly New York City. So there tend to be large urban, high African American populations within them in terms of both the old classic narcotic profile and a lot of the young polydrug and prescription opiate addicts that are coming in mixed in with that. But large samples. Okay, this is kind of the beginning of the crash course of laying kind of a groundwork for where we're going this morning. We're going to ask these questions this afternoon. If we really believed addiction was a chronic disorder, how would we treat it? We're going to ask the question, if you were only paid for successful recoveries, think about this one. If you and your organizations were only paid for successful recoveries, how would you treat addiction? Where everything that comes to you by way of resources would be contingent upon recovery outcomes, what would treatment look like? And as we've studied that, we're seeing, radical changes in the design of treatment. So our 2 modules this afternoon is we're going to look at how the acute care model changes when we move to a recovery management model and all these different dimensions of clinical practice.